Our next presenter is Dr. Aaysha Cader. The case is optimizing the Culotte technique in left main bifurcation.
Thank you very much for the opportunity to present. We know that the Culotte technique was initially described by Bernard Chevalier and colleagues in 1998 as a technique that was initially developed to, it's not running, oh sorry, thank you. Can we have the slides projected up, please? Okay, sorry. Thanks. Thank you, sir. So it's about optimizing outcomes with the Culotte technique, which was initially described by Bernard Chevalier et al. In the 1980s. And this was brought about in order to complement a provisional approach when a second stent was needed, which is known as the classic Culotte. At that time, it was studied in a small population of about 50 patients with true complex bifurcation lesions with excellent short-term results, but it didn't really take off until the advent of drug-eluting stents, where it resurfaced as a feasible technique with good outcomes. And in terms of the evidence for Culotte, it has been compared mainly with the crush technique in the Nordic stent technique study, where both Culotte as well as crush, and it's important to remember that this was actually mini crush, not DK crush that it was compared to at the time, had similar and excellent clinical and geographic results. But additionally, there was a trend towards less in-segment restenosis with the Culotte technique as compared to a regular crush. Even at 36 months, these patients who were followed up for a longer period, they found that the outcomes between the Culotte and crush techniques were similar. So what are the scenarios that one would deploy a Culotte technique at? It's, of course, in case you go provisional, it's one of the bailout management, especially where there is a large size side branch in the course of a provisional stenting strategy. But if you were to opt for a systematic two-stent strategy, the ideal complex bifurcation in which a Culotte would be suitable is one where the side branch size is comparable with the distal main branch size, as you can see in this case. There's a wide range of angles, but it's generally for an angle of less than 70 degrees or even up to around 55 degrees. And in terms of the issues or the pitfalls, if you will, is that this requires multiple steps. It's not quite as simple as a tap technique. And there's the problem of double stent layers in the proximal main branch, which over the years has been curtailed with different iterations, which I will show. So according to the EBC MADS classifications, we have Culotte, which is also in the standard technique. This is the regular Culotte, where you would stent from proximal to the distal main branch, and where a Culotte would be used as in case of a bailout if you would stent the side branch. It's also part of the inverted techniques, and this is really the systematic two-stent strategy that you would deploy. It's an inverted Culotte, where in practice you implant the side branch stent first and then stent from the main to the distal, proximal to the distal main branch. So in essence, it can be provisional as well as inverted. And over the years, starting from the classic Culotte introduced by Chevalier, they went on to reduce the proximal main branch overlap, which is called the mini Culotte. Then the DK mini Culotte, where outcomes were compared by bench testing by Gabor Toth, required a second kissing, that is a kissing after the first stent implantation. And of course, there's also DK nano Culotte, which is being bench tested by a group in Turkey right now. So this is the mini Culotte, essentially reducing or minimizing the overlap of the second stent in order to prevent a long double layer of scaffolding and restenosis. The DK mini Culotte is where an additional kissing balloon inflation is performed after the side branch stenting, prior to the main branch stenting, and this reduces malapposition as compared to DK crush. So if we were to do a case demonstration of the Culotte technique step by step in order to optimize outcomes, this was a post-CABG case with a significant side branch of a patient with intractable angina, and seeing as the fact that both the distal main branch and the side branch were of equal diameter and also of a narrow angle, we decided to go for an upfront Culotte technique. The first step is, of course, to wire both the main branch and the side branch, and it's better to wire the angulated branch first and also to pre-shape the wire, because in Culotte we have 2 rewirings during the course of the procedure, so it's important to bear that in mind unless you're going to use a third wire. So adequate lesion preparation, as is customary for any interventional procedure, particularly in culotte, is necessary. So we pre-dilated both the branches and went for what we call an inverted culotte, where the side branch is going to be stented first. This stent has to be sized according to the side branch reference vessel diameter, and also it's important that in terms of length, it has to be long enough to allow pot proximal to the carina. So after the first stent has been implanted, you would do the first pot. There are 3 pots in the ideal perfect culotte technique. So the first pot comes after the side branch stent has been implanted. This balloon should be sized 1:1 to the proximal main branch, and it's usually a short NC balloon, and it's important to leave the jailed wire in the main branch. After that, you do a rewiring of the main vessel close to the carina by the pullback technique from the side branch. This is followed by a first kissing balloon inflation. So this first kiss is what we now call the double kiss mini culotte, or the DK mini culotte, which was not part of the procedure before. Here you would use short NC balloons and a kissing balloon inflation to further open up the struts into the distal main branch. After that, you can then proceed to the second stent implantation, which is from the proximal to the distal main branch. Here, the diameter should be again sized 1:1 to the distal main branch reference vessel diameter, and the length has to ensure coverage of the proximal main branch lesion, which you want to have stented as part of the bifurcation. You would then post-dilate, or rather do a repeat pot. This is again the second pot, at the level where the pot balloon has to be placed at the level of the proximal main branch up to the carina, and should be sized 1:1 to the proximal main branch. This is then followed with a second kissing balloon inflation, or the final kissing balloon inflation, and ideally what is advised is a sequential final kissing balloon inflation, where you go at high pressures in each of the branches, followed by simultaneous kissing balloon inflation to about 12 atmospheres. And this is followed by the final pot. As I said, there were 3 times that you would do a pot, and here again, the balloon should be sized to 1:1 to the proximal main branch size and kept just before the carina to optimize the procedure. Ideally, it's best if it's done with imaging guidance, and this is the final angiographic picture, and that is what the view should look like in terms of the stent, with good coverage of the ostial side branch. That is one of the advantages of the culotte, that you will never miss coverage of the side branch ostium. So in a nutshell, these are the steps of the DK mini culotte. I mentioned there were 2 times that you would have to rewire, 2 times of kissing balloon inflation, which is why it's called double kiss mini culotte, and 3 pots in order to optimize the procedure. So in conclusion, the DK mini culotte has evolved over the years to correct pitfalls and optimize outcomes. It wasn't the best procedure, but over the years it has gotten better with multiple iterations. However, one of the issues is that it has multiple steps, but it's a good bailout option following provisional stenting, ensuring optimal coverage of the side branch ostium. It ensures, as I said, a complete coverage of the ostia and reduces stent strut prolapse. And of course, as with any technique, appropriate bifurcation lesion choice is what would guide the optimal application of the technique. Thank you for your attention.
Thank you, Benz. Dr. John C. George, any comment, please?
Yeah, that was a fantastic case demonstration.
I think we can hear you.
That was a fantastic case demonstration with a step-by-step technique of the Culotte technique. Can you comment on how you decide between Culotte technique versus DK crush versus your whatever your bifurcation strategy is? And in this particular case, you went with a planned side branch first for the inverted culotte. And can you describe the thought process for that?
In this case, we decided to go for a systematic 2-stent strategy because we found that it was a significant side branch lesion, and there was no other coverage. Also, it was a post-cabbage case, so the graft to one of the OMs was occluded, and so we figured it was a significant lesion, also according to the definition criteria, with a side branch lesion length that satisfied the criteria. As for why we went for the culotte, again, if say the side branch were of a smaller diameter, perhaps DK crush might have been a better choice, but because it was as wide as the distal reference diameter of the distal main branch, we figured culotte might be a good technique. Having said that, and also the angle was favorable. If it were a wider angle, perhaps tap might have been something that we would consider. And also, having said that, I think operator expertise is important. It's it's not everyone that can do all the procedures. For example, this is not a case I performed. It was performed by my mentor, Professor Saidur Rahman, who's sitting right next to you. So it also has to be, I think, the operator expertise, because it's obvious not everyone can do all bifurcation procedures to the same degree of expertise. And I think that's an important consideration when choosing technique choice.
I have a comment. Actually, your topic is non-left main bifurcation lesion. Actually, this Culotte technique is adaptable in bailout procedure actually. But Professor Saidur is there. He just chose a front Culotte technique. So I can ask him or ask his comment regarding why already Aaysha tried to answer it. Why not the decay crush in this, especially non-left main bifurcation lesion? Why you go upfront Culotte strategy? Operator choice is there, but you have any other consideration?
It's not always the choice or something like this, but the thing is that it's a non-left main. And again, always all the fellows, those who are here, to remember for LCX and marginal branch, always try to go for a simpler procedure rather than a complex procedure. Because LCX is an unpredictable territory. How it will behave, which two stand techniques you will apply there. It's really tough because LCX, how you will see, it's not behaving like that. Up to the marginal branch, how you will see, which is very tough to put a stand there. This is one. Second thing is that for this case, you know, the decay crush, for me, like for headache will say, yeah, I prefer Culotte rather than decay crush. Because his 53% in the EBC main trial is Culotte, and only 5% was decay crush, right? But if you go China, then they will say, no, decay crush, I will do the decay crush rather than Culotte. I hate Culotte. So this is something, it's the operator's choice or something. So why specifically for this one, which Dr. Aaysha already has told, that if you have a similar diameter, if you have a acute angulation, and almost you can understand that the two stand can cross easily, and then you can go for these things. The Culotte is not that much difficult like decay crush. Can remember. Main is easier, any procedure you can go for it. It's a big vessel there. So you have to, that's why I have done that one with upfront.
Thank you, Dr. Aaysha.